Thank you for joining us today for UCA's COVID-19 webinar on adding telemedicine to your urgent care. I'm Carla Jamieson, UCA's Education Director, and I'm going to introduce our panel for this afternoon. First of all, we have Dr. Bill Lewis, who is UCA's Telemedicine Section Leader, and he will moderate the panel today. We've also got Dr. Stanford Coleman, who is the Chief Networking Officer for Medical Affairs and Community Relations and Vice President for Right Time Medical Care in Maryland. We've got Rahul Kahare, who is Dr. Rahul Kahare, who is the founder of Innovative Express Care in Chicago, Illinois. And then we have Dr. Aisha Nikolic, who is with Ochsner Health in Louisiana. She has piloted telehealth program in their urgent care. So I'm going to go ahead and turn this over to Dr. Lewis, and thank you all for attending this afternoon, and enjoy the webinar.
Thank you, everybody, for attending. And I want to give thanks to my co-participants. We threw this together fairly quickly in response to what's been going on. And as you guys know, I think a lot of you have been on the listserv. There have been literally hundreds and hundreds of questions that have been going through the listserv about telemedicine and the expansion of telemedicine services. We have been doing pre-courses for the last 3 or 4 years, and the panelists have participated in these. And we're true advocates for telehealth. But having said that, I think this has awoken a lot of you guys up to the fact that telemedicine is a very viable option for medical care and in urgent care centers. And so the listserv has been packed with questions asking about telemedicine. How do we do it? What do we do? And what has changed since the COVID crisis has begun? So we're put this together in a very informal format. So we're going to go over some changes related to telemedicine during COVID, and then we're going to go basically have a 40 to 45 minute session of Q&A that you guys have submitted to go over what you can and what can do. And this panel is going to give you tips on what they're doing and how they do it and some best practices. So I hope that serves the purposes for the group today. Next slide. Stanford, you want to go over your program and tell them what you're doing in terms of telemedicine and what you're executing?
Thank you very much, Bill. Can you hear me?
We can.
Good. So I'm at Right Time Medical Care. We're an urgent care company covering Maryland. We have 20 locations. We've been in existence for 30 years. We treat all ages. We're open every day of the year from 7 in the morning until 11 p.m. And we also have a concussion management program called Head First, where we manage patients longitudinally for head trauma and concussion. So we've been doing Right Time now as our telemedicine solution. I think we skipped a slide there. If you could go back one slide. And we actually are doing it a little bit different than everyone else. Our platform is really our infrastructure plus a live coordinator called Simple Visit. We have a call center that we've been using since our inception, where we connect with patients for making appointments. As we started, we always had appointments in terms of seeing patients, and then we began to transition to walk-in patients, but we have retained a call center, which serves as a good infrastructure for us in terms of connecting with patients for doing telemedicine. Simple Visit is an intermediary company that we partner with, and they provide a virtual receptionist and a live coordinator to connect with the patient, connect with us as a provider, then connect us to the patient in a HIPAA-compliant, secure channel. So with this combined platform, we're able to do all of our scheduling. We can provide access to our portal to our patients that we see, and we can also do our chart documentation through the use of ECW. eClinicalWorks is our EMR, and we use it on an iPad. The strengths of this particular fashion of telemedicine is that there is a live coordinator between the patient and the provider. This person actually helps the patient, connects the patient up, ensures that the patient has a great connection. The patient can be on a laptop, can be on a cell phone, can be on a desktop, and can connect through any modality that they might have or prefer, including Skype, FaceTime, Google Hangouts, etc. So the live coordinator at the scheduled time connects with the patient, then connects with the provider, and then that coordinator drops out of the connection, and the provider is connected with the patient. We are currently seeing patients primarily and only in Maryland, and that is our geographic coverage. So since the COVID crisis, our volume has increased well over 20 times, meaning that we have generated visits that we couldn't have imagined at this state of our development. Next slide. So the ways that we're using telemedicine are really for traditional urgent care visits, for follow-up visits of those particular visits. We have also created a COVID follow-up system where when we make the diagnosis of a COVID suspected or positive patient, we continue to follow that patient. So we have a follow-up team, and that team is using telemedicine for those follow-up visits. As I mentioned before, we have a concussion management program, which called Head First, which has been in existence for about 10 years. We've see about 65,000 patients a year with that. We've transitioned that care over to telemedicine, so we're doing that through virtual visits. Then part of that staff for the concussion management program has a neuropsychologist, and we've been using telemedicine to combine with the Head First program to see those patients and even urgent care or COVID patients who are having a significant anxiety. We have physicians, PAs, certified nurse practitioners, those providers who have been trained to be concussion specialists, and our neuropsychologists as those providers in that model. We're ramping it up to cover all of our operating hours from 7 in the morning to 11 p.m. All of our training is done in-house. We're yet to determine our break-even time, and we're really very busy at this point, and it's growing very rapidly. And so our growth plans are to train more providers, more of our current providers to be Right Time Now providers, which is our branded name for our telemedicine program, and we will therefore cover all of our operating hours. So I look forward to answering your questions later on. Thanks, Bill.
You bet, you bet. Very robust program. The reason what I like about the three panelists we have is they have very different programs, and Stanford being a program being a multi-center with a very robust wraparound telemedicine program. And you're going to hear now from Dr. Rahul Khare, who has very, very unique use cases for telemedicine. I think the message here is that there's a lot of different ways you can utilize telemedicine, not just for urgent care rechecks or minor injuries. So Rahul, you want to tell a little bit about Innovative Express Care? Thank you.
Thank you, Dr. Lewis. And I want to reiterate your point there. I really love that. Each urgent care is unique. Every one of us has our strengths, what we do. Some people do more than urgent care, including primary care and other specialties. So I think you can get a lot out of this talk about how you can use different things that we're using. So what we do, we're an urgent care in Chicago called Innovative Express Care. We were 5 years old. We opened our doors seeing 5 patients a day, like a lot of you, and one was my mother, and we're up to over 200 per day. So we are a very busy urgent care, but we have used telemedicine for a variety of things in the past. So we just expanded on this during the COVID-19 pandemic. The platform we used is something called Chiron Health. We use them. They're a third-party telemedicine platform. They can integrate with our electronic health record, which is Athena Clinicals, Athena Health. We also use a third-party entity called Next Patient. This is a web-based online booking platform. There are many of these. Clockwise MD is also one of them out there. And then lastly, we use something called Yossi, which is a third-party entity that also does online registration. So once you book an appointment with the electronic health record, you still need the demographics and the picture of the ID and the picture of the insurance to get in there. And Yossi helps integrate our electronic health record into with the patient inputting from their smartphones their information. So all 4 of these things are used to integrate. You don't need all of them, but I want to make sure people understand what we use. Now, through Next Patient, and I'll give you a little visual of this on the next slide, but for right now, through Next Patient, a patient will get on our website and click on an appointment type that they want. This integrates exactly through our Athena, our clinical EHR, which then makes an actual appointment through our EHR. Then Chiron, which is our telemedicine platform, sends out a text message to the patient, getting them an account with the telemedicine platform. And then on top of that, Yossi also then sends them a text message to register and therefore put their demographics, insurance, ID pictures into our electronic health record. That's why we need all four to get all the information. Chiron Health does require a credit card, which is used to collect a copay or their self-pay amounts. And the nice part about Chiron Health and Athena is that it actually gets deposited within our electronic health record as if they were here in person. So the money goes into their account in particular. So it is a good way to collect money, especially with self-pay and with those with copays for their insurance. Strengths of our system, fully integrated EHR with all these third-party entities. The charges that the patients get through the telemedicine visits are actually captured at the point of service, right after we're done with the service. The provider puts in the amount, be it $30 or $150 or whatever the amount is. It's really easy to use for both the providers and the patients. The weaknesses, there's some weaknesses to every product. Unfortunately, with Chiron Health, if I'm running a little late, I can't text my next patient and say, hey, hang in there, I'll be there in 10 minutes. I can't really communicate them. It's all or nothing with this platform. And I can't add another person to the telemedicine visit. Some platforms you can do this. If I need a third party, maybe a receptionist to help out, I can't really add to that. We have coverage in Illinois. Next slide, please. And talking about our monthly volumes, we were seeing about 300 patients per week pre-COVID through telemedicine. Now we're seeing 800 per week through telemedicine. So it certainly has increased us greater than 100% in volume. So it's been a lifesaver for us. How we use it, we actually do COVID-19 testing at our urgent care, but we have to limit who gets the testing. We didn't want them to be asymptomatic, so we made patients do a COVID-19 screening through telemedicine to get that done. We have had 170 positive COVID-19 patients through our clinic that got tested at our clinic, and we just to let you know, we have a tent outside in our parking lot to do these because it was getting significant Lysol and taking off PPEs, the personal protective equipment for each patient. We had to take it outside to limit that and to limit contagiousness of both the waiting room as well as our employees. We also do telemedicine with all our primary care providers. We have 4 of them. They all switched to telemedicine. Any medication refills with them obviously are going to be telemedicine. And we also have 4 mental health therapists, and they are all doing telemedicine as well. Now, for our staffing model for telemedicine, it's PA, NPs, and MDs are booked via our website. The hours of coverage is, since it's telemedicine, we are pretty much able to open up our schedule. We start around 7 a.m. We stop at around 9 p.m. and we have a lot of double coverage in between. The training that it took, since all of my employees were already, all my providers were already doing telemedicine, it was already a part of our system, so we could just increase it, so there wasn't much more training. Next slide, please. That's about it. Thank you.
Great overview. 2 points here that I want to reiterate, Dr. Coleman brought up and Dr. Kari both, is if you're doing telemedicine, your visits have increased significantly, 300% and over doubled, 200% in both instances. So it's been a lifesaver in terms of volume, maintaining clinics. We know, as you guys are aware, UCA did a survey, and urgent care visits across the board from the survey that our members put in, volume in most urgent care centers is down 50%. 30 to 50 being the range. So these are practices that have implemented telemedicine, and this is applicable to all year round, not just COVID, not just in the past, but in the future too. So it's another example of why everyone should be diving into telemedicine. Next, we have an institutional system, enterprise-wide, very sophisticated and very different than the first two. So, and I'd like to welcome Dr. Aija Nikolic. Could you talk about Ochsner?
Thank you so much for inviting me to this panel. And yes, I do represent Ochsner, that is a large health system in the Gulf South. We partner with over 90 other hospitals in the area as well. And in our bricks and mortar, we are in Louisiana and Mississippi, Alabama. We're expanding to Texas, Florida, and Arkansas, just so that people get an idea of how big this system is. And I've always said at urgent care meetings, it's one thing to see it as a mom and pop shop, because that's what my original urgent care experience was. I used to own 2 sites, to now going to where we have over 19 bricks and mortar locations spanning the Louisiana state. So we use Amwell. It is a third-party platform. It's one of the biggest competitors to Teladoc out there, and it's powered by Vigio. We use this for our urgent care option in the health system. For our primary care options or our specialist options, we use an Epic-based system that's powered by Vigio as well. But we wanted to keep that separate because we wanted to have 2 different types of experiences for our customers. The beauty of the Amwell platform is that you can schedule, but you don't have to schedule. And for our urgent care platform, we decided not to schedule patient visits, but to actually have it on demand for patients. So if they wanted to come in and be seen immediately, they can be seen immediately. They didn't have to say, okay, well, let me see if there's an open slot. We also allow the patients to pick the provider they're going to see. So when they come into the app, they can see the urgent care options, and they can see which provider's there. And we staff it with physicians from all kinds of specialties. So we have pediatricians, we have internal medicine specialists, we have urgent care specialists. We also have mid-level providers or APPs, NPs, and PAs. Our Ochsner providers have all been trained to work on this platform, and during the COVID crisis, it has really helped keep our Ochsner patients safe, because this was a quick and easy way while we ramped up the other virtual platform for patients to get care from a hospital system that they trust and know. Everything is web-based, cloud-based, so the patient downloads the app. They don't have to put anything on a computer. They can go do it on a 3G, they can do it on Wi-Fi. Most patients nowadays have a smartphone, and it can be used from a tablet. There is an interface with our Epic, so that once the visit is completed, a chart gets created and that gets loaded into Epic. So if I see the patient as an urgent care patient through the Amwell app, and the patient wants to follow up with their primary care, that's an Ochsner primary care physician, it'll be in there as a chart visit, and they can review my chart and see everything in there. The strengths and weaknesses of the platform, you know, currently, just like Teladoc and Amwell, they were a little overloaded, and it took a little bit of time to catch up with that. But now over the last week, we haven't had any technical issues. But initially, I think kind of like they broke Twitter during the Oscars. That's what COVID did to a lot of technology. It's also not easily customizable. So when you're putting in a chart note or a template, that's not as easy to customize as you would have liked in Epic. There's no dot phrases. You have to kind of build it from scratch. The beauty of the platform, and I apologize for not putting it up there, is that it does reach all 50 states. It's global. You can capture people that aren't within your system, and they can be fed into the Ochsner system like that. So it's not like I just built it and only the people that know me can get to it. It's actually an open platform. The geography, like I said, it covers all 50 states. The monthly volume, I mean, I felt sad looking at how slow it used to be compared to now. We've had the same growth as everybody, you know, with over 400% in growth. So, and the use cases, the amazing thing that COVID has done for telemedicine, it has allowed for people to think outside the box. And one of the biggest things that I tell my providers before COVID, when they weren't very interested in doing telemedicine, is how many times does your mom's friend call you and say, hey, I tripped down the stairs and now my ankle hurts. And you basically do a telemedicine visit over the phone with that person. Now add video to that where you can ask the patient to touch different parts. You've just opened up that case use. So Ochsner took it a step further and partnered with Tyto. There's a Tyto Health Kit. It has a thermometer that's virtually integrates with the platform. It's got a high resolution camera, and then it's got 3 attachments to the high resolution camera. It's got a tongue depressor so you can see the back of the throat. It's got an otoscope so you can see the TM and the ear canal. And it's got a stethoscope so you can listen to heart and lungs. We have been pushing that for a while. And then when COVID hit, all of a sudden they were like hotcakes. We couldn't keep them on the shelves long enough. And that's really added that second dimension to telemedicine visits. So now when mom does a telemedicine with her kid and she's like, I don't know if my kid has an earache, you know, she's got 101 fever, started last night. Well, if I can see that TM, I know, do I need to treat this? Can we wait? And it's really providing the right care in the right place and allowing us to practice evidence-based medicine. We took that Tyto Health Kit and we put it in our bricks and mortar locations at the urgent cares. And this is something that I wanted everybody to think about. We created what we called Tyto rooms. So we had patients that could go in and do their self-exam with a blood pressure cuff, a pulse ox, do their own temperature checks, do their own exam, and we kept our providers and our frontline staff safe. And I think probably one of the biggest numbers that I didn't put up there is that of 400 staff members, we only had 13 people test positive for COVID. So I want that to sink in. In our hospital system, in the emergency room, they have 200 staff members, 50 of which tested positive. So even if you add your false negatives in there, I think our percentage speaks to how we use telemedicine. We also in the clinics used a phone triage system so that the patient, when they drive up, we'd actually triage them by phone to see, you know, how high risk are they? Do we need to put PPEs on and bring them in? So I just wanted you guys to see this as a health system, but also be able to implement this into your own practices. I think that's the only slide I have.
Very good. Some great points there, and that is that as you're thinking about implementing telemedicine, there's a lot of different systems and processes you can tag on. There is now currently reimbursement for remote patient monitoring, which could apply to the Tyto. But the important thing is the break-even point for some of these remote tools has decreased significantly, such that they're very affordable for in-home use. So if you have high-risk patients, you can send them kits, and it doesn't have to be a full Tyto kit, but remote blood pressure monitoring, pulse, temperature, it can be very routine now with telemedicine and integrated into the telemedicine platform. So if you're thinking about tying yourself to your patients and improving your brand recognition, this is a great way to do it because they know then that they're tied directly in to your clinic. Very good, guys. Thanks. Next slide. So the next 3 or 4 slides, we're going to briefly go over what has changed in regulatory perspectives in terms of COVID, because there have been some big changes. You guys have been hearing about them. And the biggest one has been Medicare. As you know, Medicare up until COVID was only reimbursed through Medicare Advantage, right? And of course, you know, your ACOs and some of your risk models. But under the telehealth reimbursement rules with COVID-19 waiver, a lot of the restrictions for reimbursement for Medicare have been removed by CMS. So as you know, Medicare had originating sites. You couldn't use telemedicine in the home. They had to be in rural physician shortage areas and certain services. So you can see in this slide the pre-COVID-19 rules and the current rules with waivers effective March 6th. So this has significantly expanded your ability to see Medicare patients via telemedicine. The other thing to remember here is that nobody knows what's going to happen after COVID. The thinking now is that they'll go back to a pre-state, but not all the way back, because they've opened Pandora's box. Medicare started reimbursing for Medicare Advantage of January 1 of this year because they wanted to do a slow one-step, two-step reimbursement for telemedicine. But now that the public is aware, the availability is aware, that the diagnostics are out there and people are experiencing it, there's a feeling that there's no way, plus the legislators, there's no way that Medicare can go back to not reimbursing for telehealth services in terms of fee-for-service business. It is reimbursing for their Medicare Advantage. So we put this slide in to give you some rules and let you know that under the current crisis, and use this as an opportunity to test, right? To get your Medicare patients involved with telemedicine, and a very effective way. Next slide. So part of the questions were, a lot of the questions pre-webinar were, how do we reimburse for telemedicine? So these are the common codes under the COVID-19 waiver. A lot of these codes are existent before the current and then under the waiver. So as you can see, telemedicine has been reimbursable for years now. You use the same 99211 through the same 99215 codes for the home, for the outpatient, and then you have the ED codes with the G modified codes. The other recently, over the last year, reimbursable codes are for virtual check-ins, e-visits, and remote patient monitoring, which are now reimbursable. I'm not going to go into detail on these. The codes are there. For RPM, there's a different code for interpreting the data. There's a different code for collecting the data, and there's a different code for the physician oversight of the data. But the point is that telemedicine reimbursement is becoming very acceptable. Next slide. So these slides are provided by InTouch Health, which is a major platform provider similar to Amwell, nationally known, so I want to thank them. This is a 2020 physician fee schedule payment rates on average for telemedicine services, for office, critical care, inpatient, and some of the virtual check-in visits. So we'll talk about this in a caveat in terms of different state regulations, but these are averages for reimbursement to give you an idea that this is a viable delivery mode for medicine. Next slide. So I put in here a brief scenario just so you could see how to code. This is an established patient at home with the COVID waivers. You can see patients at home. The call center asks screening questions. They go on the telemedicine consult. They create an AV link, and the doctor performs a remote consultation. In this scenario, you can use a 99213 or 214 due to limited physical exam. All other components are comprehensive. In this patient, we just put an ICD-10 code, contact with suspected exposure, and then you code your place of service, POS code 02, which is for telehealth, as opposed to the code for urgent care centers. Okay, next slide. So now we're going to talk about the changes that have occurred with HIPAA and COVID. And Dr. Carr, you want to handle this slide?
Sure. So what's interesting about this is that now we are able to use what used to be non-HIPAA eligible platforms. Now we're able to use them. This includes Apple's FaceTime, Facebook Messenger video, Google Hangouts video, and even Skype to provide telehealth without the risk of the OCR coming to impose a penalty. And they have written these rules. So it's really important to know that now we can use these other types of free ways of communicating with our patients, and it is now legal to do so. And this is a big change coming from the ORC as well as the HHS.
Yeah, and again, if you're starting a program and you don't want to buy a platform right away, play with this, right? Start contacting your patients, let them know, put something in your waiting room saying, if you have Skype, you Skype us, or set up a process for you to play with telemedicine. They essentially removed the barriers of entry for you to do telemedicine. And you can do it with little or no cost now because of the COVID crisis. It may be the only good thing that has come out of this is that telemedicine is going to boom as a result of the COVID crisis. So maybe there's a little sunshine at the end of this. But this is big. There were several questions relating to what I can use. Now remember, these are not HIPAA compliant platforms, and they probably will go back and remove these and take these off, because ultimately you're going to want to have a HIPAA compliant platform. But this gives you time to test and play, and then go out for an RFP or look at some of the SaaS platforms that we've discussed here, whether it's Chiron, whether it's America Well, SnapMD, Solve. There's a lot of different SaaS services as a solution platform, web-based, that really can be implemented within 7 to 14 days. If you don't want to do a lot of customization, if you take it right out of the box, in 30 days, you can have a full telemedicine platform up and running. Next slide. Aisha, you were going to do the DEA, weren't you?
Yeah. So now it's drugs for everybody. Doesn't matter. Let me take it back. So all of us know that with the Ryan-Haidt Act beforehand with telemedicine, it required that a patient be located in a bricks and mortar location. That has now changed due to some changes in legislation where they have waived it during the time of an emergency. And during the time of emergency, you can read this entire slide, but basically it allows you to write for prescriptions that are from 2 to 5, so Schedule 2 to Schedule 5, using telemedicine. The prescription, however, has to be used for a legitimate medical purpose by a practitioner that's acting in their usual course of professional practice. And the telemedicine communication has to be audio visual, and it has to be real time, and it has to be two-way. So that's the important thing. It can't be a telephone message and just a one-way, okay, I'll send it in. And then the practitioner has to be acting in accordance with the applicable federal and state laws. So that's the big thing, and I think it's exciting. And we as a system had been pushing to help our PM&R physicians to treat some of their patients and make it a little bit easier on the patients so that they don't have to come into bricks and mortars. And I think this whole COVID crisis, like Dr. Lewis said, is going to open up telemedicine and help us think differently in the future. So some of this stuff hopefully will stick.
Very good. Next slide. So the interstate practice has also been of medicine has also been modified by COVID. Stanford, you want to tackle this?
Yeah, I think this is a big opportunity for telemedicine. Up until now, there was a requirement based by most states that the provider and the patient must be in the same state. So recently, based on the COVID crisis, that has been relaxed. At least 40 states so far have written waivers to their regulations, allowing their providers who are licensed in their state to see patients wherever the patient may be. And so far, as you know, everything with COVID is changing day by day. There are 11 states so far who have not written such a waiver. So you really have to determine what your state regulations are at this point. So I want to refer everybody to the Federation of State Medical Boards website. On that website, they have a superb table that will describe each state's waiver, their regulations, what you're able to do and what you can't do, where your patient must be for you to provide telemedicine services. But this is a grand opportunity. I think that website and that table is the first place you should go so that you can see what your opportunities for telemedicine are. This will provide great growth opportunities for us all. Thank you, Bill.
Yeah, you bet. And again, it's always changing in response to the COVID. So remember, most telehealth laws are state, okay, state specific. I want to make a point in the listserv. There's a lot of people from multiple states asking questions, and a lot of people from multiple states answering questions. And I quickly look and see who's asking from what state and who's responding from what state. And I see irregularities in the fact that the people who are responding are from different states who have different regulations than the people who are asking the questions. So just please be careful and realize that if you're practicing telemedicine within a certain state, make sure that it's applicable to your state. Your medical licensing is dictated by your local medical board. So that's a state prescribed allowance to practice telemedicine within your state. It does not cross state lines, but the COVID crisis has improved that significantly. So you're going to have to refer to the table and get legal counsel. But this is an opportunity for your practices that practice in multiple states. So now we're going to go into the Q&A section. I want to remind everybody, if you have questions, go ahead and bring them in. But we've got about 50 questions that were submitted prior to the start of the conference, the webinar. And we're going to break these up into several categories. We're going to talk about vendor platform, operational issues, and there's a few more billing questions. So let's start from the beginning in terms of vendor and platform. We'll go from we'll get input from all three of the panelists. But in terms of platforms, what capabilities and functionalities do you guys think are the most important? Of course, there's a lot of capabilities that you may or may not that are unique to a different practice. Scheduling, is that important, or do you use your medical record? What functionalities within the platforms do you find? And some of you mentioned it a little bit, but can you expound on your platform itself? And if you were vending again, what would you look for in a platform that you don't have now? Who wants to start on that one? Stanford, go ahead.
Yeah, I think simplicity is the key. You want the visit to be simple for the patient as well as simple for the provider. So the way we practice telemedicine does not require the patient to download any app to their smartphone. All they have to do is know how to use a smartphone. The provider doesn't have to do anything on the provider side. Just wait for a FaceTime call from Simple Visit, the live coordinator. So that makes things very simple on both sides. The other thing is that we are able to communicate with the patient. If something goes wrong with the connection, you can move on to your next patient, and the live coordinator will work out and troubleshoot that problem with that particular patient. It's also possible to add another provider because on the provider side, the provider can connect with the live coordinator either through FaceTime or Google Hangouts. And obviously with Google Hangouts, you can add a number of other providers. So you can add another provider as a consultant. You can add another provider when you're training new providers. They can shadow you as you're doing your telemedicine visit. So I think, and the other ease of Simple Visit is the ease of startup. There are very low startup costs. Very little training has to be done in terms of connecting. We're using ECW to create our charts. So you have the ability to see all of the charts, all of the visits that a patient has had previous to that particular visit. So I think simplicity is the key that you want to look for your provider as well as for the patient.
Rahul, do you have anything to add? You bet. Thank you, Sanford. Thank you, Sanford.
I think you have to analyze. There are so many telehealth platforms out there, hundreds of them. And so I think you have to be very intentional about how you are going to use your telemedicine platform. If it is something as basic as just alternative like urgent care, that you might need something pretty simple. If this is something where You want long-term relationships with the primary care provider. If you're using it that way, then you might want something where they can log in and they always have their credit card on file and it's easy to find their appointments. So it all really is about personalization of what you're using the platform for and what your intention is.
Yeah, I agree. And I think when I'm consulting with clients, what I tell them is the first thing before I talk to them is give me your 3 use cases. And I want definition behind those 3 use cases. I want to know who, what, when, where, and how. Then I can bring, I mean, like you said, there's Chiron, there's Hypnosis, there's so many platforms out there. They all have basic core, you know, full digital cloud-based SaaS platforms. And they're all fairly inexpensive. And I can tell you that they range now from $50 per month per provider with a small licensing fee. Some are more expensive than others, but financial is not the burden. And because they're web-based RTC, you can download them. They can be pushed to every provider. You can implement these platforms very easily. But I think having a use case and knowing what you want to do is critical.
So I just wanted to add one thing. So looking at it as a system, you know, one of the reasons we chose our platform, and this is something to think about, is your geographic reach, but it's also your provider support. So one of the American Well benefits is that they had providers already trained on the platform 24/7 in all 50 states. So it didn't limit us. We went in and we went big. And really it goes back to what Dr. Carre said. You know, what are you trying to do? You need to customize and you need to be very intentional about deciding where you see yourself and what fits you. The other thing that was important to us as a system is that it integrated into our electronic medical record. If you don't care about that, you know, you can definitely use much cheaper, much easier workarounds.
You bet. Great point. How many of you guys are using your native, your EHR? Aisha, I know you are, as opposed to, how much documentation are you actually doing in the telemedicine platform, if any? Or are you just collecting the vital signs, or are you just using the audio video components of it?
So for our urgent care platform, we do a limited amount of charting in the Amwell platform. For our Epic-based virtual visit platform, we're doing everything in Epic. And we're only really using Vigio for the tele-video conferencing part.
So for us, we're using our EMR, ECW. We create a telemedicine template. And so the providers are documenting based on that template, based on a visit in a way that they're totally familiar with, that creates another chart or another visit in the list of visits that the patient might have had with the urgent care. So there's no question or worry about integration. The provider is creating a chart for just another visit using a different template.
Yeah, and for ours, we use Chiron really for the audio and the visual, the video, but also where they input, where the provider inputs the copay, or the self-pay rate. That's integrated, doesn't need to be, but it's integrated into our electronic health record. And our EHR is where we document. But the nice part of the integration is when you make a telemedicine appointment within our EHR, it actually integrates and then pings the patient through the telemedicine platform. So the integration is nice.
Yeah, and I think the point being that you can do it any way you want to. I think most providers want to stay in their native EMR and use the telemedicine platform as a secondary system to facilitate telemedicine. But there are scenarios where, you know, some of these telemedicine platforms, you can do full documentation. There's templates that are customizable if you're doing a standalone product that's different than what you're doing in your clinic. Again, it comes down to knowing what you're using the telemedicine system for and vending for the appropriate telemedicine platform based on that. As you've all noted, there's multiple systems and platforms out there. So let's go to some operational questions. Some of the questions were related to How do you verify the patient? And I think there's a lot of different ways this can be done. And then let's throw in there, tied to that also, the issue of telemedicine visit is a patient comes on and you think they need to be seen live. How do you handle that? And do you bill them twice? Or why not bill them 3 times? What the heck? Who wants to tackle that? Stanford.
So it's very easy for us. If we're doing a telemedicine visit, and I always alert the patient at the beginning of the visit that if at any point during this visit, if they are concerned and would prefer to be seen on site, to be examined by a provider, I can immediately arrange for that through our communication center and through any location that they'd like to visit. So I think that gives patients a great deal of comfort. And then I also let them know that if I feel uncomfortable during the visit, that I think that they should be seen on site, then I can immediately create a visit for them at a location of their choice immediately. So we have the benefit of having a communication center, a call center. I can directly, immediately transfer that patient to an on-site location, present that patient to the provider who's working at that time, and transfer that patient. So it's really very easy. Simplicity is always the key for us.
How do you verify the patient is who they say they are, Stanford?
Well, through the call center. When the call center is first making the appointment, they're doing the verification at that time.
So they do get a verbal, do they take pictures of the driver's license, or is it just the verbal?
Absolutely. Yes.
Okay. Anybody else?
So we have the same workflow. That's the benefit of being part of a big health system. When we are, as the physician is examining the patient, and we feel like, ooh, this needs a higher level of care, then we just tell them, hey, I'll waive your visit fee, and then I'll let the urgent care recoup that money on the copay side. I think that is not something that I would worry about too much. I always say telemedicine is kind of the Wild West. Patients don't know what to expect, and they really don't know what the limitations of virtual medicine are. And a lot of times just giving them education on what the right place is for the type of care they need is worth what they just spent on that video visit.
And I would add to that, that we don't have a huge robust team like some of you guys do. So I think what we just made policy guidelines. If we can't help them via telemedicine, then we refer them to our urgent care, and we do a no charge telemedicine consultation. First and foremost, like if we're using insurance, and we are, you can't bill the same. You can't bill them for twice in one day with the same provider. Now you can get away with doing one provider one time and then another, but I think patients just get a little weary of that. So I think right now the best practices in our minds is to help them all we can via telemedicine, and if we cannot, zero charge them, and they get further testing and evaluation in person.
In terms of expansion of services, and I'm going to tie this in, a couple questions about physical therapy being added to telemedicine. So tie that into additional services that you guys are thinking about in terms of going forward and expanding your programs, and in terms of what you've learned in the past. Because I think everyone does a tiptoe in, they put the big toe in the water, they add more services and add more services. But physical therapy is certainly something that is being added to telemedicine. Don't know if you guys are doing it, or what other services you might be thinking about adding to your program. Stanford.
So as I mentioned earlier, we do concussion management through telemedicine, and a number of those patients, based on their injuries and their recovery needs, we have been referring them to physical therapy. And I could foresee a time or even a situation where some of those patients could be managed by physical therapy through telemedicine. So that's something that's a little bit further down the road, but I could see it's a very easy transition for us to do.
So I want to say again that this is the birth of telemedicine. What Katrina did locally for us is taught everybody how to use text messaging. what COVID is doing for the world is teaching everybody to use telecommunication. You know, whether it's having group dinners at night and everybody's on their iPads talking to their friends, to healthcare. And healthcare has really taken it to the next level. We have behavioral health, we have, like I said, primary care, we have endocrine, we have diabetes programs, we have an ICU where we have a physician sitting and has 5 or 10 patients that they're monitoring from a distance. We have the teletriage in the emergency room so that they can see, is this patient, you know, high risk, which room do they need to go into, a clean room, a dirty room. I think that, again, this is something that you need to look at your piece of the pie and see what fits for you, and you can become creative with it. I mean, they're doing online aerobics classes right now. My mother, who's 80 years old, and her friends get on together and watch each other work out.
Do they watch or do they do it, Asha?
I would add one thing to that. I mean, it matters where you are in the telemedicine world, right? If you have it going, you know, adding services is great, but I would start with low-hanging fruit. You see a cellulitis in the urgent care, have an option for the receptionist to book a follow-up care via your telemedicine, a telemedicine urgent care visit. You have a UTI, and 4 days later, they're still having pain, and the culture comes back positive, but it's resistant. You know, that might be a great discussion, change of management. That's a telemedicine visit. So use your already patient population that you have and integrate it more into telemedicine. Your patients have now tried telemedicine, so they're okay with it. We had that barrier before COVID-19 where they just didn't feel comfortable with it. But nowadays, in the last 2 or 3 months, if they've seen a doctor, it's probably been virtually. So I would just add to your services, your current service, and then, yes, add on to the therapists and all the other things that you might have.
Yeah, no, first of all, the answer is yes. There are national programs of physical therapy that are doing telemedicine. And just like urgent care telemedicine, it's based on what can be effectively done via telemedicine. You think about a home exercise program. You think about a follow-up visit. You put a patient on a program, then you have an audio-video connection. You watch them perform their exercises. If they say they're doing 10 push-ups, watch them do 10 push-ups. A lot of that doesn't have to be hands-on physical therapy. If the physical therapy program is evolved that way and written that way, then the telemedicine visits can be integrated throughout the program. They have the entities that are doing physical therapy have a lot of audio-video training tools online on the patient portal integrated with the telemedicine program. So I think no matter what you look at, now that as Dr. Aisha points out, you know, the cover's off, the lid's off the cover, and there's all kinds of possibilities now that the public is and legislators and rule makers and our congressmen are accepting telemedicine. I think this is a new renaissance, and if you aren't doing telemedicine now, I hardly recommend that you seriously consider doing it, because you're going to be left in the dust. This is a competitive advantage for your program. It builds brand alliance. It keeps patients from being stolen from you. If there's a center down the street in an urgent care practice or a family practice, and they're doing telemedicine and you're not, you're going to lose patients. So when I'm talking to clients, I also talk to them about client retention, not gaining clients, but keeping the patients you have, for fear that they're going to be poached by telemedicine or telemedicine vendors. The numbers, the increased numbers you've heard in this panel are astronomical that are going to telemedicine. It's only going to increase. I've even heard a major institution saying in the future, we're going to build our bricks and mortar 20 to 30% smaller, because we don't need 13 exam rooms anymore. We need 6 exam rooms, and we need 2 pods for telemedicine. So all of these things are going to drastically change healthcare going forward. So let's switch focus a little bit now. So I want to thank the panelists again. And I remind everybody, if you have any questions, we've only got 5 minutes and I've got 3 or 4 more that we haven't covered yet. But if you have any real pressing questions, go ahead and type them in. I haven't seen any yet. So let's switch a little bit now to the question of the scope of practice. And part of this is regulated by the medical boards, but in terms of what you see and what you don't see, do you guys, do you develop practice guidelines for your providers? Do you have bumper guards? Do you let your providers go kind of ad hoc if they feel comfortable, they can see a patient? How do you manage the scope of the severity and acuity of patients that you see? Stanford?
Well, clearly we're practicing real medicine. I mean, these are real patients, some of whom could be very sick. So I think the first thing that you really have to do is train your providers very carefully. You should select your providers very carefully who practice telemedicine. They should be experienced senior practitioners who have had great experience in urgent care, know what urgent care is, and know a sick patient when they see it. And you have to provide for them not only guardrails, but you have to provide them an exit ramp where they can they understand how they can transfer a very sick patient either to the ER or to one of your sites. So I think the real critical piece is clinical judgment.
Absolutely.
I truly believe you can train anyone who can work in an urgent care to do telemedicine. There is a small amount of training that must be done. For example, if you have someone with a sore throat, you know, a self-examination of the lymph nodes with a guided examination of the lymph nodes is really important, not only to document, to get that information from it. So, you know, I think we've all been trained somehow through telemedicine, through orientations of different ways, but I think an orientation is very important, especially for self-guided exams and things like that. But I feel like if you are at a level that you can work in an urgent care, you should be able to do telemedicine. And you just have to err on the side of caution. When you can't fully evaluate a patient or you're unsure and you may need more vital signs that you can't get by yourself via telemedicine, it's time to just say, I have limitations and you need to come in. So you need to have that backup as well.
I completely agree with, you can train most people. The way we have it set up is that they have to work in our bricks and mortar locations for a specific amount of time, or a significant, I should say, amount of time before they are allowed to flip over into pure telemedicine. So far, we've only really flipped over some physicians with more experience in either ER, family medicine, or telemedicine to do urgent care. Some of our APPs we have allowed to moonlight. We have collaborating agreements for them. We have a help phone number. So if they have a question, you know, can I do this or can't I do this, they can reach out. But I go back to what telemedicine is. You know, telemedicine is limited by the fact that you can't do point of care testing yet, that you have to rely on the patient's cooperation in their exam, and that it is a little limited right now. And so if you're not comfortable as a practitioner, whether you're an APP or a physician, whether you're experienced or inexperienced, I think that the patient accepts the fact that you say, hey, you need to be seen somewhere. So I don't think that that's taken away, and somebody shouldn't feel like, okay, for patient satisfaction, I need to take care of this problem via telemedicine. I don't think anybody expects that.
You bet, you bet. So we have a question, and Aisha, this is would be for you. What are your thoughts on a partner, and you describe this, that can provide a platform, but also add your doctors to their network to take on patients off hours? Look at it as a dual partnership.
So it has worked really well for us. Thanks to COVID, we managed to onboard a lot more of our own physicians from Ochsner, because now they could no longer practice in bricks and mortar. So initially, when we didn't have as many physicians to start out with, it helped. The second thing that was huge is we didn't want to go into the tech business. So we didn't want to build platforms from scratch. We didn't want to take on the help desk number. We didn't want to take on the nurse that's on call in case something doesn't go through to the pharmacy to reach the physician that saw the patient. So there are definite benefits in having that third party that gave us not only a platform, but also providers to work with. The downside of that, and the number one reason Ochsner decided to try and build their own physicians to man the video phone, as I call it, is because we wanted to keep a level of quality as well. So that's why we added the Tyto kits. You know, we want to be known as practicing evidence-based medicine. Being in the Gulf South region, that is what we strive towards.
Good point. Good point. Well, we're about out of time. I want to close with a reminder. This language is used in almost every medical board as to what you can and can't do with telemedicine. And it really, this is the language you can see in probably 40 to 50 of the states. They say that you can practice telemedicine if the equipment is adequate for providers to exercise ordinary skills and scope and quality, the same as a live visit and the practice of normal medicine. So really what they're saying is if you can get the information in, then in terms of acuity, in terms of who you can see, severity, the right information to make the right clinical decisions. So the boards are not prescriptive on what you can and cannot see and what you can and cannot do. And that is, again, allowing you to practice good clinical judgment. So with that, it's 11:01. We want to thank our distinguished panel, not just a plain panel, a very distinguished panel, and the UCA for this opportunity. I would encourage you guys to continue to send in questions and participate in the listserv process. I think it's been very valuable for the UCA and for, I assume, all the members of the UCA, and look forward to talking with you again. Thank you.
Thank you. Thank you for having us.
Thanks. Thank you, everybody. I would just like to thank our sponsor for today, which is Xperity. As a business partner for nearly 50% of urgent care centers in the US, Xperity has put its best resources on creating solutions that support urgent cares during the COVID-19 outbreak. In March, they released a free COVID-19 response app with telemedicine functionality to help clinics manage patient remote check-ins, offer guidance, and assess COVID-19 risk. Let's watch a quick video from Xperity. Again, I was muted earlier, but we'd like to thank Xperity for sponsoring this webinar. They've been a business partner for nearly 50% of the urgent care centers in the US. Xperity has put its best resources on creating solutions that support urgent cares during the COVID-19 outbreak. In March, they released the COVID-19 response app with the telemedicine functionality, which you guys just saw the video on. So I would again like to thank everybody. Please visit xperityhealth.com to learn about the app. If you are currently an existing Xperity or Clockwise customer, reach out directly to understand their newest telemedicine functionality. Again, thank you to the panel and have a great afternoon. This will end the webinar.